If someone listening today is newly diagnosed or supporting a loved one through MDS or AML, what words of encouragement or guidance would you offer them?
I think I would tell them to hang tight, to not give up, to try to rely on, whatever brings them joy, whether it's faith. I think a lot of my patients were very faith-based or, some kind of belief in a higher power. I think that also just making sure that they have the support they need, and, not everyone does, but being available for them to, if they need, or having social workers. We had great social workers when I was at Mount Sinai who would help provide resources, support groups, and also these foundations have that kind of thing where I would advise them to try to find other people to talk to so that they feel supported and that they feel like they have help if they need.
On the podcast today, we look at hematological cancers, MDS, AML, and the breakthrough treatments offered with Dr. Shyamala Navada. And now, a word from our sponsor, BetterHelp. Is something standing between you and your happiness? It was for me. I had to face my depression and constant negative self-talk. Therapy helped me realize I deserve to be happy. That's why this podcast is called I Choose Health, because I made the choice to heal, and I want to share that with you. That's also why I've partnered with BetterHelp as our sponsor to help you start your own healing journey. We all face moments when life feels overwhelming, whether it's stress, anxiety, or just feeling stuck. Talking to someone can make a real difference, and that's where our sponsor BetterHelp comes in. BetterHelp offers professional online therapy that's convenient, affordable, and entirely on your schedule. You can connect with a licensed therapist by video, phone, or even chat, whatever works best for you. Let our sponsor BetterHelp support you on your journey to better mental health. You can get 10% off your first month by going to betterhelp.com/iChooseHealth. That's betterhelp.com/iChooseHealth for 10% off your first month. Take the first step toward feeling better today. This is 52 Choices, where you are empowered to take action on one thing you're going to change weekly to improve your health. Habit number 6. Plan your meals for the week on Sundays or at the start of the week. Are you tired of the daily stress of deciding what's for dinner? Do you find yourself reaching for takeout more often than you'd like? It's time to take control of your meals and your health with a simple yet powerful habit: meal planning. Meal planning isn't just about saving time. It's a cornerstone of a healthier lifestyle. By dedicating a portion of your Sunday or the start of your week to plan your meals, you set yourself up for success in multiple areas. And the first will be improved diet quality. A study published in the International Journal of Behavioral Nutrition and Physical Activity found that individuals who plan their meals are more likely to have a healthier diet and less obesity. Research from Harvard's Nutrition Source indicates that meal planning can help with weight control as you decide the ingredients and portions served. Knowing what's on the menu eliminates the daily decision-making fatigue, making your days smoother and more predictable. The benefits of meal planning are backed by science. A study in obesity science and practice showed that reducing ultra-processed food consumption by half, aided by meal planning, led to significant health improvements in just 8 weeks. The Harvard T.H. Chan School of Public Health emphasized that meal prep is a great tool to help keep us on a healthy eating track, contributing to an overall more nutritionally balanced diet. Now here are some practical tips to get started. First, you want to set aside some time. Dedicate 30 minutes on Sunday to plan your meals for the week. Second, make sure you're doing an inventory check. Review what you already have to avoid unnecessary purchases. Third, create a menu. Plan meals that are nutritious and aligned with your health goals. Fourth, make a shopping list. Based on your menu, list the ingredients that you need. And last, prep ahead. Wash and chop vegetables, marinate proteins, or cook grains in advance to save time during the week. Embracing meal planning can transform your eating habits, improve your health, and bring peace to your daily routine. Start this Sunday and make meal planning a non-negotiable part of your week. By incorporating this habit into your weekly routine, you're making a choice that benefits your body, mind, and schedule. Happy planning. All right, guys, welcome back to the I Choose Health podcast. I'm your host, Stefan Lessie. Now, guys, on this podcast, we've had a lot of people on here sharing their experiences, where they've overcome some really extenuating circumstances. We had Ruby on here last year, where she spoke about her challenges with ovarian cancer and how she overcame that. And oftentimes, our motto here at I Choose Health is, allowing your stories to help others overcome. But from time to time, we're definitely going to need experts who are going to help us understand what it is that our friends, our families, even ourselves at certain times are going through, dealing with conditions like cancer or dealing with other ailments that may come our way. And so our guest today, she's going to help us understand a little bit better some of the things that we probably should understand about cancer, and particularly certain cancers as well. She has worked on designing early phase clinical trials, investigating the role of novel candidate drugs to improve the outcomes of patients with MDS and AML, and has served as principal investigator on multiple investigator-initiated and industry-sponsored trials. Dr. Navada has a Master of Science degree in clinical research from ICANN. Dr. Navada has presented her research at national and international conferences, including the American Society of Hematology the American Society of Hematology annual meeting, International Bone Marrow Failure Disease Scientific Symposium. I wish that they would kind of make these things shorter. International Symposium on, you're going to have to say it for me,
myelodysplastic syndromes.
There you go. And European Hematology Association Congress. Dr. Navada is involved in education of community physicians and patients on the treatment of MDS through the Aplastic Anemia and MDS Foundation. So Dr. Navada, welcome to the I Choose Health podcast. How are you doing today?
How are you? Thank you for inviting me.
Yes, thank you for coming. Now, before we dive into the science, can you tell us what first drew you to oncology, and more specifically to MDS? I'm going to keep saying MDS because I cannot pronounce this word, and acute myeloid leukemia.
Yeah, you can call that AML, so that's the abbreviation.
Okay.
Acute myeloid leukemia. But no, thank you for this question. I think I knew I wanted to go into medicine for a long time. I think since I was young, there were no doctors in my family, but I kind of always was interested in science, and I had this desire to kind of work in a scientific field, but also be able to help people. And so, the path is long. You go through your 4 years of college and then 4 years of medical school. And in medical school, you have to kind of decide what field you want to go into for residency. And a lot of people choose either medicine or surgery. That's a simplification, but it's kind of, which type of subspecialty will you do? And I knew I wanted to do something within internal medicine. So I went into residency at University of Michigan for internal medicine, but I didn't really know what specialty I wanted to do. And I went back and forth, do I want to do cardiology? Do I want to do GI? I think it was my rotation in oncology as an intern in my first year that really kind of solidified my interest in cancer medicine. And there were two things. One, I had a great mentor. So the attending physician, who's the one who supervises you for that rotation, we got along really well, and I learned a lot from him. But also, just seeing the types of patients who came in and how much of a difference you could make for them, how sick they were, but also how appreciative they were when you took care of them, and just kind of seeing their disease course play out, seeing the potential innovative new drugs that we could test out, and seeing patients potentially get better. I think that all influenced me. So during residency, you then apply for fellowship, and at that point, I decided to apply for hematology oncology.
And was there a moment early in your career, like a patient or experience, that made you realize this was more than just a research path, but your life's work?
So I think that was, also during my oncology rotation. So at the University of Michigan, there was just this robust profile of clinical trials. And so the experience of seeing patients come in, many of them really sick, and then being able to offer them novel therapies to help them get better. I was just intrigued by the level of research in the field, how, there was so much we knew, but there was also so much we didn't know. To add on to that, just to see how much has changed since I started, and how many better therapies we have now, but we still have so much work to do. So I think just kind of knowing that there would always be excitement in the field and possibilities to move the field forward.
Got it. Now, for those of us who are unfamiliar, can you help paint a picture of what it's like to live with MDS or AML? And for those of you listening, and for those of you who are going to be watching this, I'm going to post that full name up there. But for those who are unfamiliar, can you help us paint a picture of what it's like to live with MDS or AML from both the patient's and the physician's perspective?
Yeah, so MDS and AML are hematologic malignancies. So, kind of to simplify cancers in a way, we can use the bucket of solid tumors, which are things like breast cancer, colon cancer, lung cancer, and then liquid tumors, which are cancers like multiple myeloma, lymphoma, and MDS and AML fall under that liquid tumor and heme malignancy bucket. And so these patients often have a challenging course. And to talk about MDS first, because that was my main subspecialty, the average age of patients with MDS is in their mid-60s to early 70s. So, a lot of times these patients have other medical conditions, often have a harder time getting around. And the disease, for many patients, they have to come into the clinic often for treatments, whether they are blood transfusions, which take hours, or supportive care injections where they have to come in frequently. So it's a lot on a patient and then also on caretakers. I noticed a lot of caretaker burden when I treated patients, because a lot of times patients would come in with an older spouse who was really responsible for taking care of them. And then I think for the physician, it can be challenging because the treatment options are limited. Now, in the last few years, we have had several drugs approved, but there's still limited treatment options, in my opinion. And so you try everything you can, but at some point you may or may not have treatment options for a patient. And we only have one curative option for MDS at this time, and that's a stem cell transplant. And a lot of patients are not able to get to that point because they may not have a donor, or they may be too old, or they may have other medical conditions. Now, AML can afflict a whole range of age of patients. We have younger patients, older patients, but one of the challenges for AML, and it's kind of scary because you have a patient come in, let's say you have a young patient come in and they were fine, and then all of a sudden they were feeling tired for a couple of weeks, or they noticed their gums were bleeding, or something unusual, and they come to the hospital and we find that they have AML, and often we have to admit them to the hospital right then and there for an entire month at least. So imagine how difficult that would be for someone to hear that. And they may be at school, they may be working, and so to navigate all of that is very challenging. There are also outpatient treatments for AML now and clinical trials, but it's tough to have that conversation with patients when they come in and you're on the inpatient service. I think the other big challenge for these patients, for both, is that with low blood counts comes the risk of infections, the risk of bleeding, and that all contributes to an increased risk of morbidity and mortality. So it's challenging.
Yeah. Now, I know you said that there was a particular age range where people with MDS are usually affected. Is there a reason why that age group specifically?
I think that's well understood, and a lot of times we don't know why patients get MDS. We know there's some risk factors such as smoking, benzene exposure, prior chemotherapy or radiation for another cancer can cause what is known as a secondary MDS. And I have seen younger patients with MDS, patients even in their 20s and 30s, but the majority, the median age is 65 to 70. It's likely a combination of environmental exposures and then also genetic alterations that perhaps as we age, we're more likely to obtain abnormal mutations or other characteristics that increase the predisposition to these diseases.
And of course, we don't want to guess anything, but seeing that, as you said, there are hematological illnesses, there are blood cancers, if I'm understanding that correctly, that it may be a buildup in the blood over time. I can be wrong in terms of how I'm seeing that, because I know that cancer is mostly developed in the cells, if I'm understanding that correctly as well. And so I'm just trying to understand if that is a potential, because, I don't want to say we're playing this guessing game on the podcast, because I'm not an expert, you are, but, I'm just thinking about it as you're explaining it.
Right. Now, I think you have a point, because we are now learning, or we have learned, but we're investigating pre-malignant conditions. So the names of them, one of them is called CHIP, and it's called clonal hematopoiesis of indeterminate potential. And so in other words, there's abnormalities in a patient's bone marrow, and we see an abnormal clone in the bone marrow, but we don't exactly know what it is. And those patients have an increased risk of developing myelodysplastic syndrome. So it could be something that's developing in the bone marrow over time. And I have seen patients that were referred to me where they had abnormal blood counts for a while, but maybe they weren't worked up right away, because not everyone is going to refer a patient to a hematologist. Or sometimes a patient has a low hemoglobin and a doctor may think, oh, they just have iron deficiency, or they just have some kind of, they're just anemic, they're older. But actually, they should be worked up because they could have the beginnings of a blood cancer. They may not, but they could. So it's always important to do a workup when a patient has abnormal blood counts.
Right. Now, I know that your work bridges clinical and translational research. Can you share an example of a clinical trial that you led, perhaps one where the outcomes surprised you or your team?
Yeah, so one clinical trial that I worked on that I actually presented the results of in different conferences was a combination trial of a novel agent with a standard treatment used in MDS, standard treatment being a drug azacitidine. And we were working with a pharmaceutical company on this trial. And so once a patient fails azacitidine and has higher risk MDS, actually there's still no approved therapies in that population. So the prognosis is guarded. And we tested this combination and actually saw some promising results in patients, and it was really encouraging and exciting to see that, and I was able to present that at conferences, and it was just really nice to see patients living longer than what we expected. Unfortunately, the sponsor, it was a smaller biotech company, and the sponsor was not able to move the trial forward, so it didn't get approved. It's no longer in development for this disease, which was unfortunate, but I did see some patients benefit, and that was really exciting.
Yeah. And now, speaking of the patient's benefit, you lightly touched on this already, but what's it like to tell a patient that a new drug you helped research might actually extend or improve their life? And are there any moments that stick with you?
Yeah, so that actually is, I think, really exciting when you're able to tell a patient that you have a new option to treat them. Now, I know with clinical trials, you can't promise anything because you're still testing the safety and efficacy of a drug. But when you actually have a new FDA-approved drug for a patient and you've seen that it has either extended survival or improved symptoms, quality of life is so important for these patients, then I think that is really special. And one case that stands out to me, so, during my time in academia, a drug called venetoclax was approved in AML, and that drug has really been groundbreaking, a game changer for AML patients. And I had a patient who was in her 60s, so relatively young, and had tried all different treatments, had the disease for probably a decade easily, tried all different treatments, and then at some point I put her on a clinical trial and that didn't work. And then I gave her an FDA approved drug. It wasn't really approved in the setting that she was in because she was at a point where she had no approved treatment options. But I tried that in combination with another approved drug, and she had a stellar response. And it was just so nice to see because I was, really kind of preparing her for more supportive care, hospice, and her counts practically normalized. And it's unusual. I think even my colleagues were surprised at how well she did. And, I took care of her for many years after. So that was a really nice example of how a new drug came to market and really benefited a patient.
So, I know that in the health and medical field right now, there's a huge request for things that are natural or holistic. Do you ever have instances where you guys are looking into, one, holistic options, and then two, people who are requesting those type of drugs or those type of treatments?
I think that happens pretty often nowadays. Honestly wish for our clinic we had someone who had more training in that because I think patients take a lot of supplements and other treatments to potentially help their disease. Now, if it comes to something like yoga, meditation, I am all for that. When it comes to supplements, particularly for these disorders, sometimes I think they're great. Other times I don't know if some supplements could potentially interact with the treatments they're on for their cancer, or if they could affect the blood counts. And so I would try to do my research when they asked me and look things up, but sometimes there's just not enough information online to find that. And I think having someone with specialized training in that could be really helpful. At some point, I did want to investigate that a little more, but I ended up not. But I think it's really important because for so many patients, having supplements, nutritional additions to their diet, things like that are really important. But yeah, I think for holistic, definitely mind-body connection is so important. And I think whatever people can do to decrease stress, which has been shown to affect cancer, and just calm their mind, I think that is...
And is this interesting that something that seems so simple can actually have such a huge impact cellularly? And, with that, I know that you've been deeply involved in educating both patients and physicians through the Aplastic Anemia and MDS Foundation. What do patients often misunderstand about MDS or AML? And what do you wish more doctors were emphasizing? And I want to also piggyback off the idea of what is there about cancer that we do not really understand in terms of the development of it?
Yeah, so I think in terms of education, particularly for MDS and AML, I think there's a lot unknown and a lot misunderstood. Sometimes patients don't understand what their treatment options are. I think a lot of physicians in the community, if they're only treating a few MDS patients, maybe they're treating more solid tumor patients, they may not always understand what treatment options are available. And so I think it's really important, and I would recommend patients to get a second opinion with an MDS specialist if they can, because it's a very nuanced field. I think sometimes patients don't know their options for clinical trials, and I think clinical trials are an important piece of the treatment, the armamentarium of treatments for patients. And then sometimes I also think that physicians don't keep patients on treatments long enough to see them work. And we did some research on this back when I was at Mount Sinai. They see maybe a dip in blood counts for certain treatments initially before they get better, and then they get scared and they take the patient off treatment. Or maybe certain treatments may cause fatigue in the beginning, which may eventually improve. So I think it's really important that patients understand what treatments are available, and then also that ideally they should stay on a treatment long enough to assess for a response, unless they're having significant toxicity or side effects from it. And then in terms of, can you repeat the second part of your question?
Yeah. So what do patients often misunderstand about MDS or AML? What do you wish more doctors were emphasizing?
Yeah, I think that goes along with some of the treatment options, and not necessarily knowing next steps, not knowing the options for supportive care, not knowing the risks sometimes of having low blood counts. So I think it's just education around it is really important. And I also think patients need to know whether their disease is curative, whether we're doing more supportive type therapies. So I think all of that is.
Now, what kind of determines whether or not MDS or AML or maybe any other cancer is non-curative? Where does the cancer have to get to where, we say, well, that it doesn't seem like this thing can be cured, but you can only deal with the symptoms of it?
So for MDS, the only curative option is a bone marrow transplant and an allogeneic stem cell transplant. So in other words, you can't get your own cells, you have to get cells from someone else. And so that is a curative option, but patients need to have a donor. They need to be healthy enough to get a stem cell transplant. And so different institutions have different cutoff ages often for how old they would transplant someone, because you want the benefit to outweigh the risk. And then for other cancers, it kind of depends on the kind of tumor. So each cancer is very different. You often think of stage 4 cancers, the ones in solid tumors that have metastasized, so that have spread to other parts of the body. So with colon cancer, lung cancer, breast cancer, if they've spread outside of that organ, a lot of times they are not curative, although some treatment options have changed where you can get patients into durable remissions, but I often think of those as not curative. There can be exceptions. And so I think for solid tumors, you think of when a cancer has spread that it's much more difficult to cure. But early stage cancers are more curative for a lot of those solid tumors. We don't stage, we do have staging for heme malignancies, but it's not kind of the stage 1, 2, 3, 4 that you see more frequently in solid tumors.
Now, Dr. Navada, I know that your research is mostly in cancers and looking at different cancers, but have you been able to, has your team been able to see what link there is between nutrition and the development of cancers?
I think nutrition is such an important part of cancer development. Although I have not been directly involved with this research, I know there's a lot of interesting clinical research going on in this arena. There's a colleague at Sloan Kettering who has been doing all this research on plant-based high-fiber diets and how those have actually been able to help patients with multiple myeloma by improving gut health and by eating a plant-based diet. She's actually been able to show that this can help decrease progression once patients have early stage disease, which I think is fascinating. And I think the more we look at, we see more of an increase now in younger patients getting cancer and also getting more advanced cancers, right? One of them being colon cancer. And so I think there likely is some link with diet, environment, toxins, obesity. Not for everyone, but I do think there's probably some link in what we're putting into our bodies and patients developing these cancers. And we don't fully know yet, but I do think that studies that have looked at nutrition really do show that a healthy diet, a high fiber, plant-based diet can be beneficial for patients to either reduce the risk or reduce progression of cancers.
Now, you said that you're starting to see a lot of younger patients with these cancers. When you're looking at the demographics of it, how often is it that you're seeing this, particularly within American individuals, or is it something that's kind of spread out across the world?
I would say definitely within American individuals. I think that's where I've heard more cases. I'm actually not sure about the epidemiology in other countries, but I know that it's been an epidemic here in our country that we've seen a rise in younger patients getting cancers. It'd be interesting to look and see what the epidemiology is in other countries, and is there any link to diet, environmental toxin, stress, and other features.
Now, we talked about nutrition, and I want to go into something else as well. So I didn't mention this at the start of the podcast, but Dr. Navada is also a client of mine as a personal trainer. Can you also review, if any, the relationship between the proliferation or reduction of cancer cells and exercise?
So, yes, I think exercise is another really important piece of our daily lives. And I do think that we know that obesity has been linked with different types of cancers. I'll use breast cancer as one example. We know that there's a higher risk of, well, it's one of the risk factors for developing breast cancer. And I think that's the case with many cancers, colon cancer as well, many different malignancies. And so I think that exercise plays such a key role in, one, reducing the risk of obesity, and then also I think as a stress reliever, because we, although I don't know that we have any pure evidence, I think there's a lot of link to stress and cancer. And I think exercise really can help reduce stress by strengthening the body and getting us moving. So I think that I think there's definitely a link and a positive benefit to exercise.
Now, do you recall a story where a patient or their caregiver, after receiving proper education or support, took a more empowered role in their care? And how did that change their outcome?
Yeah, I guess one example I can think of is I had a patient who had acute promyelocytic leukemia, and she came in actually feeling well. And that's one of these cancers where you never know, someone could come in really sick or they could come in okay, but then there's a high morbidity and mortality from bleeding from that cancer and from developing clots. But it's also very curable cancer if you find it early. And so she really advocated for her health, came in and had had a rough course in the beginning, but kind of really did well and still doing well to this day. Asked a lot of questions, made sure she followed up on everything, came in more than she needed to after she got her treatment to follow up, and just kind of really took a positive step in terms of improving her health afterwards. Starting to exercise more regularly. I'm really thinking about her diet, backing down from her very stressful job where she was burnt out, and vacationing more, spending more time with her family. And I think all of that had a positive impact, and she continues to do well today.
Great. Now, with all that you've accomplished, presenting at international congresses, leading trials, mentoring others, what still keeps you up at night and what keeps you hopeful?
I think what keeps me up at night is that we still have so much more work to do. And as we continue to come up with new treatments for cancers, we continue to also see the lack of options we have for certain patients. And, no one's going to live forever. We know that eventually, for some cancers, patients will succumb to their disease. For others, we may be able to help them for a certain period of time, but not cure them. But I do think there's something to also be said about helping someone die with dignity and die well, and support their family through it. So I think knowing that we still have a lot of work to do is what keeps me up. But I'm really hopeful that over the time that I've been doing this, we've seen so many improvements. We've developed so many new drugs that are very effective, but also have less toxicity and are more tolerable for patients, more treatments that can cause certain cancers to almost behave like a chronic disease, like hypertension or diabetes, where they take a pill or they can come to the office every few weeks and get an injection or an infusion and actually still go to work and live their normal life. So I think we've made a lot of progress.
Now, with what you said in terms of the things that still keep you up, do you think that there is a behavior within the medical industry that maybe keeps us from discovering more about cancer and the treatment that we could probably affect? Do you think that there's certain maybe obstinate, or I guess you could say like people who are kind of like resistant to different ways of thinking when it comes to cancer?
I think it's a mix. I think at least for the places and people I've worked with, there's always been an open-mindedness to collaborate and to come up with new treatment options and to really help patients. So I'm lucky in that way that I've experienced that both in the pharmaceutical industry as well as in academia. But, I do think there's a lot of issues in, getting, not a lot, but there are issues in getting drugs to market. Obviously, there has to be a lot of regulation because you don't want a treatment to get to patients that's overly toxic or not effective. But then the process is often long and drawn out, and there probably are some drugs that maybe could have helped people that never made it. And, I used the one I treated, or that I studied as an example. Like that drug never made it to the trial phase where it could have actually potentially made it to market and helped more people. And so I'm sure there's other drugs like that could have benefited patients but never had the chance to. So I think it's finding that balance of doing the work, but then also making sure that there's the right amount of regulatory oversight where you're not harming patients.
Right. And where do you see the future of MDS and AML treatment headed in the next 5 to 10 years? And what role do you hope to play in shaping that future?
So I see more personalized medicine. I think as we know more now about molecular mutations and genetic profiling, and we really try to target certain mutations to help an individual patient, so we know more about what's going on with their disease. It's not a perfect science and things can change, but I feel like we are coming up with newer therapies and hopefully more effective and less toxic therapies. So that's an exciting part of, what I think the future holds. And for me, I'm working at my pharmaceutical job now in drug development, which is really exciting, so that hopefully I can help to develop new therapies or new combinations for patients. But I'm also planning to go back and work in academia part-time at Einstein Hospital to work on the inpatient heme malignancy service there. So I'm really excited to be able to see patients again and treat them and put them on clinical trials and hopefully see them get better. So I think this kind of hybrid type role is something I'm really excited about, to be able to see patients, but also to work in drug development.
Yeah. And if someone listening today is newly diagnosed or supporting a loved one through MDS or AML, what words of encouragement or guidance would you offer them?
I think I would tell them to hang tight, to not give up, to try to rely on, whatever brings them joy, whether it's faith. I think a lot of my patients were very faith-based, or, some kind of belief in a higher power. I think that, also just making sure that they have the support they need, and, not everyone does, but being available for them to, if they need, or having social workers. We had great social workers when I was at Mount Sinai who would help provide resources, support groups, and also these foundations have that kind of thing where I would advise them to try to find other people to talk to so that they feel supported and that they feel like they have help if they need. Because, I mentioned that a lot of caregivers for MDS in particular are older, have their own medical problems, and so it makes it challenging, really, for the patient and their caregiver.
Now, for many Americans, I know that a lot of them do not have access to at least good health care. What would be potentially a good place to start for someone who maybe does not have access to certain types of medical care or certain types of medication? What probably should be their first step if they're not able to go that route?
Yeah, that can be really challenging. And I was lucky at Mount Sinai to have a great team of social workers and pharmacists and case managers who were able to work wonders and get medications for patients for us. But I know a lot of times it's not that easy. Some patients don't have insurance, or their insurance may deny treatments that can be life-saving. So I think, one thing I would say, and I know not everyone has access, but, if they're able to get to an academic institution that could potentially help them, if they, can find a good social worker or someone who can advocate for them, because sometimes there's a lot of paperwork that needs to be filled out in order to even get medications. And, some patients who don't have access may also not have the ability, whether it's because they don't feel well or they don't have support, or the questions that are asked in some of these forms can be really challenging. And so I think that's a major barrier still. I think that there's a lot of work that needs to be done for access. And I think just trying to find the right group of doctors, social workers, healthcare providers that can help the patient is just so important. And I hope, and I don't know what the future holds. I really hope that insurance companies and pharmaceutical companies and doctors can all really work better together to help patients get the treatments they need. I know that's very idealistic.
Well, Dr. Navada, thank you so much for taking your time, your care, and your expertise to share your knowledge with us. And this is the part of the show where we give the guests the opportunity to share what they have next, stuff they're working on next, and then also where we can find you on social media so we can reach out to you as well.
So in terms of what I'm working on next, I'm going to be starting this new position soon at Montefiore Einstein. And so I'll be seeing patients there in the inpatient service. I'll continue to do my work at Geron, working on drug development and clinical trials. So I'm excited to be doing both of these things and helping patients and helping in drug development. And then I'm not very active on social media. You can find me on Facebook, on Instagram, and on LinkedIn.
All right, so we're gonna definitely follow you there, and we want to applaud that. So I'm gonna put that in the chat. It is good for us to have people in the medical field who really do care about the work that they're doing, and that goes for any field, right? But especially the medical field, where we come to you, as doctors, oncologists, and scientists to help us with these major medical issues that we have. So we're definitely thankful to you for the hard work that you've been doing these many years, and definitely thank you for just sitting down with us and sharing your knowledge with us.
Thank you. This was great. Thank you for inviting me.
Yes. All right, guys. Well, again, this is the I Choose Health podcast. I'm your host, Stefan Lessie, just reminding you that when you choose health and you choose yourself, you're choosing power, purpose, and possibility, and that you're choosing to be a story out there to empower and to help someone else that is maybe in a similar position to you. So again, this is the I Choose Health podcast. I'm looking forward to seeing you guys next week.